Thank you for being with us today. Thank you for attending this infertility symposium at Insert Group in Colombia. For the next 25 minutes, we're going to talk about hysteroscopic myomectomy in infertile patients. My name is Juan Giraldo. I'm gynecologist. I'm a human reproduction specialist and specialist in gynecologic endoscopic surgery. So, very important, fibroids are the most frequent tumors in women. All women can have the possibility of having fibroids during their life, and 7 out of them, of 10, are going to have a diagnosis of fibroids sometime in their life. Basically, in patients with infertility, about 30% of them are going to have fibroids when they come consulting for infertility. So we definitely need to know how to work, how to manage, and how to take care of these fibroids in couples and in patients with infertility. And there's many mechanisms why fibroids can cause infertility. Well, of course, there's a mechanic effect on reproduction. And that mechanic effect causes a physical impedance to the transportation of sperm, eggs, and embryos in the female reproductive tract. Also, there's an alteration of the uterine contractility, and this causes chronic inflammation in the endometrium of patients with fibroid. It's also been shown that there's an altered cytokine production and that women with fibroids have a diminished interleukin-10 and glycodelin production at the endometrium. Also, they show a diminished HOXA1 gene expression in the endometrium. And we all know that HOXA1 are genes that are really implicated in embryo implantation. So that diminished expression of HOXA genes can accomplish a diminished implantation rate. Also, patients with fibroid have an alteration in the endomyometrial junctional zone. And this endomyometrial junctional zone can have also diminished concentration in macrophages and uterine NK cells. So all these aspects can cause infertility in patients with fibroids. So when we're talking about fibroids and infertility, we need to discuss this paper that was published in 2009 by a great American doctor called Dr. David Olive and his wife, Dr. Elizabeth Pritch, that working in Wisconsin, in the University of Wisconsin, and their own fertility institute, they did a systematic review of evidence of the effect of fibroids in fertility. And they talked about intramural, subserosal, submucosal fibroids, but we want specifically to talk about submucosal fibroids. That's what has our attention today here. Because all the controversial evidence that was at that point active about fibroids, they did this systematic review. And they wanted to determine the effect of fibroids on infertility and the effect of myomectomy on the reproductive prognosis of these patients. So they did a systematic review that dealt and addressed the clinical pregnancy rate, the miscarriage rate, the ongoing pregnancy rate, the live birth rate, and the implantation rate, and the premature delivery rate in women with fibroids, and those taken to myomectomy. So they studied and they included 23 publications, 1 RCT, 9 prospective publications, and 13 retrospective publications. So as I said, we're only going to talk about the analysis of the submucosal fibroids. So when they compared patients with submucous fibroids with a general population of women without submucous fibroids, they saw, as you can see in this table, that the clinical pregnancy rate, the implantation rate, and the ongoing pregnancy rate and the live birth rate were diminished in patients with submucous fibroids compared to controls without submucous fibroids. And that spontaneous abortion rate miscarriage rate was increased in those patients with submucous fibroids compared to controls without any submucous fibroids. So apparently submucous fibroids do have an effect on fertility prognosis. They also compared those patients with submucous fibroids that were taken to surgery against a control group of patients with submucous fibroids that were not taken to surgery. So no myomectomy was done on this control group. And those patients that were not taken to surgery had a diminished clinical pregnancy rate, as you can see here, statistically significant. But they also compared those patients with myomectomy with those infertile women that had no fibroids, and saw that there was no difference in the clinical pregnancy rate, in the implantation rate, and the ongoing pregnancy rate and miscarriage rate. So patients that had submucous fibroids had lower pregnancy rates, clinical pregnancy rates, than those that were taken to surgery before looking for a pregnancy. And when they were taken to myomectomy, their behavior was similar to those infertile patients that didn't have any fibroids. So again, the evidence shows that submucous fibroids definitely have an effect on fertility. After that publication in 2013, a new publication addressed 5 more series of patients taken to hysteroscopic myomectomy that were followed for approximately 12 to 24 months. This 5 series included between 250 and 300 patients taken to hysteroscopic myomectomy. And during this period of follow-up, 1 to 2 years, you can see that the percentage of pregnancy in those patients were ranged from approximately 30% to 60%. So definitely hysteroscopic myomectomy seems to have a positive effect on the chance of these patients of getting pregnant. Nevertheless, in 2020, Cochrane published a systematic review about surgical treatment of fibroids for subfertile patients. And they reported that patients with submucous fibroids that were taken to myomectomy compared to those that were not taken to myomectomy didn't have a statistical difference in terms of their clinical pregnancy rate. But when you go deep into the analysis of this systematic review, you can see that this submucous fibroids analysis was done based only in one RCT that was published by Cassini in Gynecological Endocrinology in 2006. And that RCT only included 52 patients with submucous fibroids. 30 of them were taken to myomectomy, 22 of them were not taken to myomectomy, and they were followed for 1 year. And if you go deep, even more deep into the analysis, you can see that those patients that were not taken to myomectomy had a clinical pregnancy rate in that year of 27.3, and the 30 patients that were taken to myomectomy had a clinical pregnancy rate of 43%. And if you compare that, definitely there is a difference. Maybe not statistically significant because of the low number of patients, but definitely a trend to have a higher pregnancy rate if you took the patient to a myomectomy, hysteroscopic myomectomy for those submucosal fibroids. So it seems that submucous fibroids diminish the prognostic in terms of reproduction for this patient. It seems that a hysteroscopic myomectomy restores or at least increases the possibility of getting pregnant after the surgery for those patients with submucosal fibroids. But when we see the different kind of fibroids, there's specifically one kind of the submucosal fibroids that causes real difficulty in the possibility of treatment. And these are the FIGO2 fibroids. FIGO0 fibroids are the ones that are completely intraluminal. FIGO1 fibroids are the ones that have most of its component intraluminal and has less than 50% of its component in the myometrial wall. But FIGO2 fibroids are the ones that have more than 50% of their component, of their volume, into the myometrial wall. So those are really difficult to resect because hysteroscopically you can resect easily the intraluminal portion, but it's really difficult to resect the intramyometrial portion. And laparoscopically, it's very difficult to do a resection because those fibroids do not protrude in the serosa, so they're really difficult to identify in laparoscopy, where you don't have the sensitive touch to be able to identify the location of the fibroid. So those are the fibroids that we saw pretty common in many patients and that we wanted to be able to resect in a safe and effective way for these patients. So there's several ways to do a hysteroscopic myomectomy. First, you can do a conventional resection with the resectoscope, and you can use a monopolar resectoscope or bipolar resectoscope, depending on the instruments that you have in your institution. But definitely you need to use some kind of energy to do a resection. The second way would be to do a vaporization, not a resection, but a destruction of the tissue with high power energy. That's vaporization. The third way to do it is morcellation of the fibroids. We all here have heard about Bugatti morcellator or MyoSure morcellator. That's a instrument that has high cost, that it's not available in many institutions, unfortunately, but that's a possibility. And finally, the enucleation, that the most common enucleation is done through the resectoscope using a cold loop. So usually what's done in this case is that the intraluminal portion is resected with energy, and then with a cold loop, the intraluminal portion is enucleated and released into the intraluminal or the endometrial cavity, and then it's lysed again with a resectoscope to be able to take the rest of the fibroid out. So there's pros and cons to each of these techniques. For example, resection. Which are the pros? Well, there's the most experience. Most surgeons are trained to do a resection, a hysteroscopic resection, and it's a standard technique. What are the cons? That you need to use energy. So there's the risk of thermal injury, basically to the neighboring myometrial tissue. So with the energy, you can cause damage to the myometrium around the fibroid. Of course, if you're using monopolar energy, you need hyposmotic solutions, and hyposmotic solutions have related complications related to electrolytes, and of course, cerebral edema, and pretty serious complications that we want to avoid. There's decreased visibility. We all have dealt with chips of the fibroids that we still have 50 or 70% of a fibroid to resect, and we're full of chips that are not letting us see the rest of the fibroid to be able to resect it. It's a longer surgical time, many times, because you need to take small chips one by one, take them out, go inside again, fill the cavity again with liquid, and that takes time. And definitely because it's difficult to identify the healthy myometrium in the intramural portion of those fibroids. When you resect the intraluminal part or portion of the fibroid, it's really easy. But once you need to get into the myometrial cavity to resect that rest of the fibroid that is included in that myometrial wall, then you start to lose the limit between healthy and pathological tissue. And there is where you can cause thermal damage to the surrounding myometrium. About vaporization, there's pros, of course. It's faster than resection because you don't have all those chips. The tissue is obviously destroyed by the vaporization. You can use it for larger fibroids, so that's good. But cons is that you also can have thermal injury because you need to use really high power energy to be able to vaporize these fibroids. There's impaired visibility because of the bubbles that are produced, and there's possibility of gas embolism. There's risk of gas embolism, so that's a con. You also need hyposmotic solutions with all the related complications, like electrolyte-related complications. And there's no tissue available for pathology analysis. The third one is morcellation. It's pros that it avoids the need for energy, so you don't need hyposmolar solutions, so that's good. There's no electrolyte-related complications. There's no thermal damage, so that's nice. And it's faster, of course, because you don't have those chips. The morcellator is taking the tissue on real time. Meanwhile, you resect the fibroid, so that's good. But the cons is that it's expensive, that it's not available in many institutions, that the equipment is, well, really, really expensive. Most surgeons are not trained on this technique, and it's not useful for FIGO2 fibroids that are the ones that we're concerned about, because you cannot get the morcellator in the myometrial wall where that part of the intramural part of the fibroid is located. So it's not useful for these kinds of fibroids. And the fourth is the enucleation. That's good because you don't need, well, you need less hyposmotic solutions, and there's lower risk for thermal injury, because when you resect that intraluminal portion of the fibroid, then you can use saline, and meanwhile you're using Helen, you can use the cold loop to enucleate the residual portion in the myometrial wall, and well, that makes it easier. Then you need to resect, to put in the resectoscope again and use energy to resect that enucleated portion of the fibroid. The cons are that most surgeons are not trained in this 100% cold technique. It needs cervical canal dilatation from the beginning, and you need highly qualified training. So this is a systematic review that was published in 2020 by this Italian group of Ugo Indracolo, and they addressed the challenge of hysteroscopic myomectomy, of resecting the intramural portion of the submucous fibroids. So they wanted to evaluate the viability of doing this hysteroscopic myomectomy in a one-step procedure. And they compared slicing, well, conventional resectoscope, with other options of enucleation of that intramural portion of the fibroids. And they did a systematic review with prospective and retrospective case reports, and some RCTs and case control studies. And I don't want to go into the analysis because we don't have time for that. But basically, their conclusion is that in FIGO2 fibroids that have more than 50% of intramural volume, the slicing technique allowed the complete resection in one single surgical procedure, one-step procedure, in 70% of the patients. Meanwhile, the techniques that included enucleation of the deep portion of fibroids showed that myomectomy could be completed in a one-step procedure in 88% of the patients. So it seems that resection, conventional resection, is not the ideal way to do a resection in those FIGO2 fibroids, that we need to use techniques that allow us to enucleate that deep portion of myomas to be able to do this in a one-step procedure. So these are the fibroids we're worried about, the ones that have most of its volume inside the myometrial wall. So that's why we developed and published this technique. We published it in 2021 in Fertility and Sterility. It's called Hysteroscopic Myomectomy for Submucosal Type 2 Fibroids with Cold Enucleation Technique and Complete Fibroid Extraction using a double lumen intracervical cannula. So what we do is that we go in with a hysteroscope, we enucleate with a hysteroscope the fibroid, then we dilate the cervix, and we use a double lumen intracervical cannula that we developed that allows us to place in the hysteroscope, the diagnostic hysteroscope, and also it allows us to place in the endometrial cavity at the same time a laparoscopic tenaculum that can grab the enucleated fibroid and extract it completely without leaving any fibroid in the intramural or the myometrial wall. And of course, we don't need to use energy because it's all a cold procedure. So I'm gonna place and play now the video that we published in Fertility and Sterility so that you can understand this technique a little bit more.
Hysteroscopic myomectomy for submucosal type 2 fibroids with cold enucleation technique and complete fibroid extraction using a double lumen intracervical cannula. The purpose of this video is to introduce a new double lumen intracervical cannula designed to allow a single-step hysteroscopic myomectomy with non-fragmented complete fibroid extraction after cold enucleation of submucosal type 2 fibroids, avoiding complications related to the use of energy and hyposmolar solutions. We present the hysteroscopic surgical procedure performed in a 45-year-old patient with abnormal uterine bleeding consisting of poly-N hypermenorrhea, non-responsive to medical treatment caused by 3 FIGO type 2 submucosal fibroids of 17, 15, and 13 millimeters with more than 80% of intramural component. Transvaginal ultrasound images demonstrate 3 fibroids with submucosal component. These were numbered from the uterine fundus towards the isthmus. Fibroid number 1, anterior fundal 17 mm type 2 fibroid. Fibroid number 2, posterior corporal 15 mm type 2 fibroid. Fibroid number 3, left lateral ischemic 13 mm type 2 fibroid. Before the surgical technique, it's very important to have an extremely clear ultrasonographic fibroid mapping before performing the hysteroscopic surgery for fibroids with a predominant intramural component. Disadvantages of conventional hysteroscopic resection for FIGO type 2 submucosal fibroids. Fibroids intramural component technically difficult to access. Partial resection that frequently needs an additional hysteroscopic surgery. Potential thermal damage to neighboring healthy myometrial tissue. Potential complications related to the use of hyposmolar uterine distension media. Hysteroscopy was performed using the Vetokis hysteroscope with a single flow 3.9 mm sheath and normal saline as uterine cavity distension media. Fibroids were properly identified according to hysteroscopic findings and previous transvaginal ultrasonographic mapping. Fibroid number 1 of 17 mm with a 20% submucosal component. Fibroid number 3 of 13 mm with a 15% submucosal component. Fibroid number 2 of 15 mm with a 10% submucosal component. As the illustration shows, with the telescope's distal end bevel, pressure is applied over the reflection angle between the fibroid and the endometrium in order to access the fibroid's pseudocapsule. Blunt dissection is performed in this plane with the hysteroscope's tip always under direct visualization until complete fibroenucleation is achieved. Fibroid number 3 in the ischemic left lateral wall is enucleated using the described technique. As you can see, once the pseudocapsule is ruptured and with a subtle pushing maneuver with the hysteroscope's tip, the fibroid bulges into the uterine cavity, facilitating the completion of the fibroid's enucleation. Constant visualization of the surgical plane is fundamental to avoid uterine rupture, which is not only considered a complication of this surgery, but also a reason to cancel the hysteroscopic procedure due to the loss of intrauterine distension pressure caused by the fluid loss through the myometrial defect. Fibroid number 1 in the fundal anterior wall is enucleated. Fundal fibroids pose a further challenge for blunt enucleation since the pushing maneuver from the fibroid's base with the hysteroscope's tip is not feasible. This blunt fibroid enucleation is a hemostatic procedure. If adequately performed, no considerable bleeding occurs when keeping the hysteroscope's tip in the appropriate surgical plane, the pseudocapsule. As you can observe, fibroids are enucleated but not completely released from the fibroids fovea, hoping that they will not be moving loosely and can be easily grasped once their extraction is attempted. Fibroid number 2 in the posterior corporeal wall is enucleated. Adjacent healthy myometrial tissue is kept intact without any thermal-related injury. Its anatomic and functional integrity is preserved, which is of crucial importance for fertility patients. All fibroids must be enucleated before cervical dilation is performed. Otherwise, distension of the uterine cavity wouldn't be optimal due to transcervical fluid loss. Visualization would be poor, and the enucleation maneuver would become technically difficult. All 3 submucosal fibroids were successfully enucleated without detaching them from the fibroids fovea. Now, they are ready for complete fibroid extraction. At this point, as the illustration shows, cervical dilation was accomplished with Heger plugs and extraction of the fibroids performed with the parallel and concomitant insertion of a laparoscopic tenaculum forceps in order to grasp and pull out the fibroids under direct visualization. To overcome the challenge of having an excessive retrograde fluid loss through the dilated cervix during the fibroid extraction, we designed a cylindrical double-lumen metallic cervical cannula that adapts itself perfectly into the dilated cervix. This device has 2 lumens through which the Betocchis hysteroscope with a single flow sheath and the laparoscopic tenaculum forceps can be introduced into the uterine cavity simultaneously, keeping these 2 aligned for adequate visualization. Enucleated fibroids are extracted starting from the lowest and ending with the highest fibroid in the uterine cavity, with the purpose of avoiding lower fibroids getting in the way and causing an obstructive effect. Fibroid number 3 is extracted with the laparoscopic tenaculum grasper under direct visualization. Fibroid number 2 is extracted. Fibroid number 1 is extracted. Complete and unfragmented fibroid extraction is achieved without any residual pathologic tissue left on site. This was an ambulatory surgical procedure with a total operative time of 32 minutes, which seems to be considerably shorter when compared with conventional electrosurgical techniques. The total amount of normal saline distension media used was 800 milliliters with a liquid balance of 50 milliliters. No hyposmolar distension media was required. No surgical or anesthesia-related complications occurred. The patient's postoperative course was uneventful with minimal postoperative pain, high patient surgery-related satisfaction, and complete normalization of menstrual cycles. Postoperative transvaginal ultrasound images demonstrate a complete restoration of the endometrial cavity anatomy with appropriate endometrial thickness and appearance, as well as normal myometrial ultrasonographic characteristics. Conclusions. Hysteroscopic complete unfragmented type 2 submucosal fibroids with deep intramural component extraction can be performed in a single intervention. The double-lumen intracervical cannula allows this technique, avoiding the need for electrosurgery and its related complications. This surgery can be performed with the use of a diagnostic hysteroscope widely available worldwide in gynecologic practices. Thank you.
So that was the video we published in Fertility and Sterility and the case report that shows the technique that we developed, the double lumen cannula that we developed as well, to be able to extract this complete fibroids in patients basically with infertility and with very good advantages in their possibility of conserving their healthy myometrial tissue and of restarting their fertility treatment really soon after this surgery. So we want to share with you our experience with our surgery and our technique and our developed technique. Up to now, we have had 47 cases. You can see here of those, basically the average age is 40 years old. The average size for the fibroids, it ranged between 6 millimeters and 35 millimeters with an average size of 17 millimeters. This ideally is a technique for fibroids up to 20 millimeters. We've done bigger fibroids, but it's much easier to do fibroids of 20 millimeters or less. We've resected 64 fibroids with a range of 1 to 7 fibroids per patient and an average of 1.8 fibroids per patient. Almost 53% of the patients have other kinds of fibroids, intramural fibroids, that we definitely didn't resect. We only were worried about the FIGO2 fibroids. 32% of the patients had a previous uterine surgery. 45 of these 47 patients had an infertility diagnosis. So almost 96% of the patients were in infertility treatment. 2 patients didn't want a pregnancy and just were worried because of abnormal uterine bleeding. The average infertility duration of these 45 patients was 39 months. And 10% of the patients had previous offspring and 13% had previous miscarriages. We could successfully do or perform a complete surgery, one-step procedure in 43 out of 47 patients. In 4 patients, the surgical time ranged from 6 minutes to 60 minutes with an average time of 20 minutes. So you really diminish the surgical time compared to conventional resection. We needed a second surgical step in 4 patients, in 8.5% of the patients. We had intraoperative complications in 5 patients, 10% of them. We're going to let you know which ones in the next slide. We didn't have any postoperative complications. We had additional intrauterine disease, basically synechia, Asherman disease, uterine septa, and polyps in 15% of the patients. And when we did the surgery, we did an interview to the patients with a scale to know their opinion on the scale of pain, postoperative pain, and the postoperative satisfaction. So in terms of pain, we had a scale of 1 to 5, being 1, no pain at all, 5, lots of pain. And most patients answered between 1 and 4 in terms of pain, with an average of 1.9. So it's really not much pain in these patients. 1 in the scale, 2 of pain is just mild pain. So you can see that most patients referred to have either no or mild pain. And according to satisfaction with the surgery, most patients went from 3 to 5, being 1 not satisfied at all, or 5 very satisfied, and the min grade was 4.9. So patients were really satisfied with the surgery experience. These are the complications. We had 5 complications. We have 2 cases of uterine perforation when we were starting with this technique. 1 patient had a uterine perforation, but she was already programmed for a laparoscopy in the same procedure because he had an endometriosis. So what we did is that we had a uterine perforation, and we did a suture, only 1 stitch in that perforation, and no consequences went further than that. That patient had a live newborn after that surgery. We had another patient with a uterine perforation. In this case, we had to stop the procedure. She had a positive fluid balance. Of course, the liquid went through the uterine perforation into the pelvic cavity. And we did an additional hysteroscopy to extract the fibroid that had previously been completely enucleated. So it was really, really easy to do this second step surgery. And the other 3 complications were basically positive fluid balance over 1.5 liters of saline solution when we wanted to, or we made the decision to stop the surgery and do an additional surgery to complete the procedure. And according to reproductive outcome in these 44 patients, so we had among the 45 patients that we considered for the analysis that had interest in infertility, 1 was a patient that had a complete surgery, abandoned treatment and came 3 years later and again had submucosal fibroids. So that's why we have 45 cases, but for prognostic outcome, we consider that patients as 1, not as 2, as we consider it for surgical analysis. So that's why we have 44 patients for the analysis of reproductive outcome. Of those 44 patients, 8 had a spontaneous pregnancy. Of the patients that were managed with expectant management, 9 of them were managed with expectant management, 8 got pregnant, so that's 88% of the ones that had indication for expectant management. Patients pregnant with ART were 18 of those 44. Patients that had indications for ART and that were taken to ART, 18 were pregnant out of 35 for a 51% pregnancy. And 5 patients had a post-myomectomy miscarriage. Of those 5 patients, 4 got pregnant again and had a live newborn after having a miscarriage. So of all the 44 patients, finally 25 patients had a live newborn for a 56% pregnancy or live newborn rate after the submucosal myomectomy with this technique. Actually, we have 13 patients still in fertility treatment, and 6 patients had treatment discontinuation. So our technique has several pros. First, a complete FIGO 1, 0, 1, and 2 fibroid resection in a one-step surgical procedure. 2, we avoid electrosurgery and its related complications. 3, we have a diminished surgical time compared to other techniques like conventional resection. 4, we restore uterine and endometrial anatomy without affecting myometrial functionality. 5, we avoid hyposmotic solutions and their related complications. And finally, we have a diminished surgical complication rate with a resulting adequate uterine environment for optimized future fertility outcome. Thank you very much. I'm open to questions, and I hope you liked this technique and you can use it in the near future.